Hi all. So let's start with fetal Doppler examination. So what is fetal Doppler? It is like we are assessing the blood flow passing through the placenta. So there are many arteries involved. There can be a uterine artery, there can be an umbilical artery. You will read about further that there's involvement of babies, fetal middle cerebral artery, ductus venosus of the fetus. So we assess the flow in various of these arteries. So if there is any abnormality, in the blood flow, obviously the resistance will increase, the blood flow will be hampered. So we get to know at which point, at what level is the umbilical artery, the blood flow is hampered, and through that we get to know about the cause. So fetal Doppler is used for fetal growth restrictions and diagnosis of fetal anemia. So we can use fetal Doppler for diagnosing fetal growth restriction and fetal anemia to know the cause exactly of fetal growth restriction and fetal anemia. So this is the waveform that happens when the blood is passed through the vessel. So this is the highest velocity that the blood passes through. This is called a systolic velocity, and this is the diastolic velocity. So the blood is passed through the fetal circulation both in systole and in diastole. All right. So if I calculate the ratio between the two, it is S by D. So this is the SD ratios. If I calculate S minus the D ratio divided by the mean velocity, I will get a pulsatility index. Similarly, if I calculate S minus D divided by the systolic, I'll get a resistive index. Alright, pulsatility index and a resistive index. You need to know these two. Now let's move on. Where all we calculate fetal Doppler? I told you we calculate fetal Doppler in various arteries going from the mother to the baby. So one such artery is obviously the uterine artery. Then comes the umbilical artery. Then in the fetus comes the middle cerebral artery. This is cerebral placental ratio. I will teach you how to calculate. And this is aortic isthmus and a ductus venosus flow. So uterine artery. So uterine artery. So what happens here? If the mother comes to you with preeclampsia, we'll surely be doing the Doppler in those female, because we want to know if there is abnormal uterine artery Doppler. It is done. So this screening is done at 20 to 24th week. In what is pulsatility index, we have seen what is resistive index. So if these two increases, we call it a abnormal uterine artery Doppler. So the cutoff is whatever is more than 95th centile. So from where we can get these centiles? These centiles are available online. We just plot the values. We'll just plot what is our PI and our RI, and we see if it's more than 95th centile, then that means there is abnormal. That means it is abnormal, and we know that there is increased resistance to the blood flow in the umbilical artery, in the uterine artery. So what is the significance? Blood flow from the uteroplacental circulation is hampered, and if it's abnormal, it reflects placental resistance. So the clinical value, it helps in prediction of the perinatal outcome in early and late FGR. Now comes the umbilical artery. So umbilical artery represent the blood flow in the fetoplacental unit. The sequence of increased resistance leads to increase in systolic by diastolic ratio. We have learned about various ratios. So there will be increased SD ratio, there will be increased resistive index, there will be initially absent flow, and then it becomes a reversal flow. So you can see this is the flow that you see during a normal pregnancy in umbilical artery. Alright, this is the systolic flow, this is the diastolic flow. And if there is abnormality in the umbilical artery, the systolic flow is preserved, but there is decrease in the diastolic flow, as you can see from here. So there is a decrease in diastolic velocity. As the problem further progresses, there is just absence of diastolic flow. The diastolic flow completely diminishes. It's just like touching the baseline, that is absent in diastolic flow. If the problem further persists, So the forward flow that I was telling you about, the forward flow that happens during systole and diastole, the forward flow in the diastole becomes negative. That is reversal. There is reversal of flow. This is emergency situation to the baby. You do not want baby not to have a forward flow. So this is the emergency situation because you do not want baby to have a reversal of blood flow. All right. So we do emergency sections during this stage. So now comes, we have now entered the fetus, and now we are measuring the middle cerebral artery Doppler. So the middle cerebral artery is obviously artery in the brain which assesses velocity to the fetal cerebral blood flow. All right. So fetal brain is a high resistance circulation is already present. There is a continuous forward flow both in the systole and diastole phase of the cardiac cycle. Fetal anemia. The MCA Doppler is used to diagnose fetal anemia. How it is diagnosed? We measure the peak systolic velocity in the middle cerebral artery. If it is more than 1.5 times the median or higher, we get to know that fetal anemia is there. When do we do fetal anemia? When there is a suspicion of high drops in a baby, if and we want to know whether the baby has severe anemia, so we assesses the peak systolic velocity in MCA. So for MCA, you need to know what is a brain sparing effect. So brain sparing effect is nothing but what happens in brain sparing effect, that whenever there is a threat to the fetal circulation due to any cause, what the body does is it preserves the blood to the vital organs like the brain, the kidney, the adrenals. So there is increased flow in at the cost of decreased flow to the other organs. So this is known as the brain sparing effect. So fetal growth restriction, low oxygen delivery, blood is preferentially distributed to vital organ like brain, heart and adrenals at the expense of non-vital organ. So there will be vasodilation in the brain circulation scene. So fetal growth restriction, MCA Doppler, and diastolic blood velocity in the cerebral vessels increases and pulsatility decreases, which is referred to as brain sparing effect. So in MCA Doppler, you will find increase in diastolic flow because there is increased vasodilation in the MCA artery in order to preserve the brain. All right, so there will be increased blood flow trying to normalize. So that is what we are here to detect. If there is increased blood flow, if there is increased vasodilation in the MCA. So see, this is the waveform of a normal MCA artery. If there is mild hypoxia, there will be increased vasodilation. So that, see, the diastolic blood flows increases here. You can see here. Can you compare this with this? So if there is mild vasodilation, there is increase in the blood during the diastole. If there is marked hypoxia, there will be marked vasodilation. So see, the depth of diastolic flow has increased so much. So we know this is abnormal if this is so much vasodilated. This is the normal flow that we expect in MCA. If we see a flow like this, we know there is something wrong. The baby is suffering from some sort of hypoxia. All right. So the abnormal cutoff, anything pulsatility index of less than 5th centile is abnormal. So significance, blood flow to the fetal brain. When abnormal, it reflects fetal brain vasodilation, a surrogate marker of a fetal hypoxia. So the clinically, it helps in prediction of perinatal and neurological outcome in early and late FGR. So if the MCA cutoff continues to be less than 5th centile, we know there can be a poor neurological outcome in the baby. Moving on, the cerebroplacental ratio. It's important, you should be knowing about it. It is a diagnostic index. CPR is calculated by dividing MCA by the umbilical artery. We divide MCA pulsatility index by the umbilical artery PI. In setting of fetal growth restriction and in response to hypoxia, cerebral vasodilation leads to increased diastolic flow and decreased MCA pulsatility index. That we got to know, that I have taught you earlier. So what happens if there is increase in diastolic flow and decrease in MCA? So the CPR decreases obviously because it's a ratio of MCA by umbilical artery. The CPR will decrease. In setting of fetal growth restriction and response to hypoxia, cerebral vasodilation lead to increased diastolic flow and decreased MCA PI. So where all we see low CPR. Low CPR with abnormal cerebral autoregulation between 24 to 48 hours after birth. It is associated with high risk IUGR, low birth weight, decreased ABGAR, postnatal acidosis, IVH and death. So what is the abnormal cutoff for CPR? It's less than the 5th centile. Significance, what is the significance of it? It combined information of fetal brain redistribution and placental resistance. Obviously it's a ratio between the two. It is a cerebro-placental ratio, so obviously it gives information about the fetal brain redistribution and placental resistance. Clinically, prediction of perinatal outcome in early and late FGR. So if I try to explain you here, it is a ratio between middle cerebral artery to umbilical artery. So for a CPR to be low, the MCA should decrease and the umbilical artery pulsatility PI should increase. So obviously, when there is increased resistance in the umbilical artery, the PI will increase. We have seen what is an abnormal umbilical artery PI, that is more than 95th centile, right? So we know that. So if it increase and MCA decrease, our CPR will also decrease, which is seen in which can lead to IUGR, low birth weight, low decreased ABGAR, acidosis, IVH and death. So abnormal CPR, anything less than the 5th centile is a abnormal CPR. Significance, it gives a combined information of fetal brain and placental resistance. So we have covered that. Now come to aortic isthmus Doppler. This is more of theoretical. So what happens here is it is associated with increased fetal mortality and neurological morbidity in early onset FGR. It balances between the impedance of the brain and the systemic vascular system. Reversal of AOI flow is a sign of advanced deterioration and a further step in sequence with umbilical artery and MCA Doppler. So if the problem comes in the uterine, then comes in the umbilical, then comes in the MCA, then it further progresses and it goes to aortic isthmus. So if we see problem in aortic isthmus, we know it's advanced stage. Alright. AOI has a strong association with both adverse perinatal and neurological outcome. So the abnormal cutoff is reversal diastolic flow. Significance, blood flow through the aortic isthmus. It reflects the balance between the resistance of the brain and systemic vascular resistance. So I have told you all that. Now come ductus venosus. What is ductus venosus? We know when the blood that is coming from umbilical vein, from the mother to the baby through umbilical vein, it shunts through ductus venosus before going to the IVC, right? Ductus venosus act as a shunt between the oxygenated blood from the mother through umbilical vein and the IVC. All right, so it's a shunt. So if there is abnormality during that, so see, ductus venosus flow velocity assesses the cardiac preload, that right heart failure. You know the IVC leads into the right atrium, so obviously it's a preload stage, right? It is the right heart that is involved here. Whenever ductus venosus is involved, you know it has to be the right heart that is failing if there is abnormality in the ductus venosus, because it is a shunt between umbilical vein and the IVC, and the IVC leads into the right heart. So now the next point, ductus venosus Doppler reflects physiological pressure changes in the right ventricle. Normally there is a uniform continuous flow in the ductus towards fetal heart through cardiac cycle. Normal ductus Doppler is biphasic. First peak represent ventricular contraction, that is S wave. Second peak represent ventricular diastole, that is D wave. And third correspond to atrial contraction, that is A wave. In contrast to umbilical and MCI Doppler indices, where Doppler changes are seen in early stage of FGR, ductus venosus changes are seen in the advanced stages of FGR. Ductus venosus is the strongest single Doppler parameter to predict a short-term risk of fetal death in early onset FGR. So if I am seeing the mother, and if I get to know that the baby is FGR and I'm performing the Doppler and I have performed Doppler for umbilical artery, I've performed Doppler for uterine artery, MCA Doppler, and now I'm doing ductus venosus Doppler. And if I find there is abnormality in the ductus venosus, then I have to counsel the parents regarding a poor outcome. I can expect like I have to counsel them regarding one of the possibility of fetal death if the case in cases of early onset FGR. Because I know the situation is bad if I'm detecting ductus venosus in early onset. Consistently, there is a good correlation of abnormal ductus venosus waveform with late stage acidemia. So if there is acidemia, there has to be poor outcome with the baby. So what is the abnormal cutoff of ductus venosus? More than 95th centile, or a reversal arterial flow pattern. Significance: blood from umbilical vein to the fetal heart. It reflects fetal heart diastolic function. Prediction of perinatal mortality in advanced stages of FGR. So what is the temporal sequence of fetal Doppler abnormality? So it starts when your your umbilical artery, it starts with your uterine artery pulse. It starts with you it starts with your uterine artery PI of more than 95th centile. All right, then your cerebro-placental ratio, or your MCI PI, becomes less than 5th centile. So there is a hampering of the blood vessels in the uh, fetus and the placenta. So that leads to absent end diastolic flow in the umbilical artery, which leads to reversal, which further progresses to reversal flow, which leads to aortic isthmus and ductus venosus PI of more than 95th centile, which leads to absent or reversed A wave in the ductus venosus. Then there will be pulsatile umbilical vein. Then there will be CTG and biophysical profile abnormality, and then it will be fetal acidemia and stillbirth. So this is how the situation progresses from uterine artery to CPR to absent end diastolic, reversal end diastolic, aortic isthmus and ductus venosus abnormality, then absent or reverse A wave in the ductus venosus, pulsatile umbilical vein, abnormal CTG and biophysical profile, fetal acidemia and stillbirth. So that is all for this video. Thank you so much for your patient listening. If you have any doubt, please write it in the comment. I'll be happy to assist. Thank you so much.